Good afternoon, teachers, seniors, and colleagues. So, we shall start RHEUMACON 2025 Calicut. So, the first day we'll be having the basic topics. So, straight away starting. Thank you.
Good afternoon all. So let's start the academic session, and I invite the chairs for this session back to the basic. Dr. Meera Essen, consultant rheumatologist, KIMS Karunagapalli. Dr. Abraham Mohan, senior consultant, Caritas Hospital, Kottayam. And Dr. Abhilash Kannan, senior consultant physician, Cosmopolitan Hospital, Thiruvananthapuram.
Good afternoon, everyone. I am happy to start the session. I invite Dr. Anup C. for our first talk. He is a consultant rheumatologist in KIMS Al-Shifa Perindalmanna. He is qualified in DM Clinical Immunology and Rheumatology from MMC and has various publications in national and international journals. The first topic is crosstalk between immune cells and stromal cells in rheumatoid arthritis. We know there are fibroblasts like synoviocytes which interact with our immune cells and increase the niche for rheumatoid arthritis and its propagation. So we welcome you, sir.
Good afternoon, teachers, seniors and colleagues. Thank you for the kind introduction, and thank you for giving me an opportunity to present. This is my first RHEUMACON experience, and I'm happy to open the sessions from RHEUMACON 2025 in Calicut. Why we have to talk on this topic? As we have an explosion of biological agents and other targeted synthetic TMARDs which revolutionized rheumatoid arthritis treatments, but still many patients continue to progress despite the immune suppression. And the disease reactivates rapidly after stopping the therapy, which tells us that there is some disease memory that is happening, and this reactivates suddenly after stopping the treatment. And the joint damage is localized, and there are some tissue resident drivers that keeps the joint damaged. And even after treatment, the immune infiltrates often decline, but the synovial hyperplasia persists. So there was a paradigm shift of from immune cells to stromal cells, especially synovial fibroblast in rheumatoid arthritis pathogenesis, along with other stromal cells like tissue resident macrophages, endothelial pericyte unit, and follicular dendritic cell. And in rheumatoid synovium, there is an expansion of the lining cells, and there is expansion of the sublining cells with massive proliferation of fibroblasts like synoviocyte and other stromal cells, along with the immune cells that are coming from the blood. And the synovium, which produce a lot of cytokines and chemokines and forms an expansive pannus and destroys the cartilage and forms the pannus. The fibroblast has in the healthy synovium, it has a supportive role, but in RA, it has a destructive or immune role. Along the pathological functions, we have to stress on two things, that is the invasion and matrix degeneration of the fibroblast, and the fibroblast as an immune or inflammatory cell. And it is, all we know that it has resistance to apoptosis, and it has a high index of proliferation, and fibroblasts create a memory, the fibroblast memory. Because of this, why there is a fibroblast memory that causes a long-lasting inflammatory programming? It is because of the epigenetic changes. The epigenetic fibroblast memory explains why RA remains a chronic disease even after the immune or inflammation falls. And in the synovial fibroblast, there are different molecules that has the property of helping the synovial fibroblast to produce destruction and immune activation. And one of that is Dec13th. It is basically a protein that mediates adhesion between two cells, but it also regulates the behavior of a fibroblast in RA synovium, and it converts a fibroblast into an invasive pannus in rheumatoid arthritis. So depletion of this Dec13th may help in rheumatoid arthritis treatment, which was successful in mouse models. And there is different types of synovial fibroblast in synovium. One thing, lining and sublining fibroblast. And we can see that the yellow cells, that is the FAP, fibroblast associated protein alpha positive lining fibroblast, and the Thy1, THY positive sublining fibroblast. And the lining fibroblasts promote the bone erosion and destruction of the cartilage. That is more important in osteoarthritis. And the sublining fibroblasts later become the inflammatory cell in rheumatoid arthritis, which is Thy1 positive and produce different cytokines, chemokines, and act as an immune cell in RA. So fibroblast as an immune cell, it is one of the major producer of IL-6 in the synovium of rheumatoid arthritis. If you map all the fibroblasts in rheumatoid arthritis, there is a group of fibroblasts which is Thy1 positive, and that is sublining fibroblast, with HLA-DR positive, which is the genetic marker of rheumatoid arthritis, which produce high amount of IL-6. Not only the IL-6, it also produce different kinds of cytokines and chemokines, and polarize the Th17 response from the ectopic lymphoid structure in rheumatoid arthritis. Then how it is becoming an inflammatory cell? It is basically because of the help of endothelial cell. You see that the synovial sublining is supported by endothelial cells, and endothelial cells drives the fibroblast to become an immune cell. So there is a interaction between endothelial cell and the synovial fibroblast, which is the Notch ligand in the endothelial cell and the Notch3 receptor in the synovial fibroblast, which produces which creates an inflammatory type of cell in synovial fibroblast. So Notch3 is a zip code dictating whether it is an inflammatory fibroblast or a destructive behavior fibroblast. Going deeper into the fibroblast, whenever there are different stimulations like TNF or IL-17, there are downstream pathways which activate LIF and STAT4, which produces a lot of IL-6 from fibroblast. So these LIF in terms again go to the LIF receptors in the synovial fibroblast, and there is a amplification loop happening inside the fibroblast. Even if you cut off the TNF or IL-17 stimulus, this amplification loop mediated by LIF continues, and this is why whenever, even if the inflammation is decreased, the synovial hyperplasia or the fibroblast proliferation continues, and this may cause destruction. And other cell, the third cell that is helping is tissue resident macrophages, as this is one of the cells that comes from the embryonic life to the joints in the embryonic life itself, and it keeps locally renewing inside the and it produces a protective barrier to the joint and forms an immune surveillance role. And in rheumatoid arthritis, there is a loss of lining layer tissue resident macrophages, which causes a flare or flare in rheumatoid arthritis disease. So there are a lot of interconnections between these cells, tissue resident macrophages, endothelial cells, and synovial fibroblasts, which in turn interact with the immune cells in the synovium, which aggravates or produce the joint destruction ultimately in rheumatoid synovium. So why we have to discuss about synovial fibroblast? Historically, we know that there are a lot of different histological types in rheumatoid arthritis, like lymphoid or diffuse myeloid type or fibrotic or post-immune type. So even in the fibrotic or post-immune histological types, targeting these fibroblasts may be helpful in treating these kind of patients. And there is a group of patients, in one study there was refractory multi-drug resistant rheumatoid arthritis. Fibroblast signature or fibroblast gene signature matter in this group of patients. So targeting these group of patients, targeting fibroblasts or other stromal cells may be helpful. So how we can target these stromal cells? First of all, blocking the fibroblast activation. That is what we are doing now. We are doing targeting TNF, IL-1, IL-17, interferons. So we use NSAIDs, glucocorticoids, DMARDs, biological DMARDs, even GM-CSF, which is tried in rheumatoid arthritis, and kinase inhibitors. That is what we are doing now. So going into again deeper, you can disrupt the pathological behavior of a fibroblast, like in inhibiting the Catherine-11. We know that the Catherine-11, we already told it, it makes a fibroblast into a spanners in rheumatoid arthritis. So you can disrupt this Catherine-11. Even if the mouse studies were successful, the human trials was not that successful with Catherine-11. And you can disrupt the pathological behavior also by the pathways inside the fibroblast, like cyclin-dependent kinase inhibitor, which can inhibit the cell proliferation and survival and induce apoptosis in rheumatoid apoptosis. Celecyclib is one of the molecules that has been tried in rheumatoid arthritis, which is in phase 1b trial, which is a traffic trial. And we already told the autonomous amplification loop that is happening in the fibroblast. We can disrupt these autonomous amplification loop by targeting LIF or LIF receptors. So even if you have a TNF or IL-17 stimulus, this targeting cut off this autonomous amplification loop makes the rheumatoid make the disease activity less. And you can alter the fibroblast differentiation into an immune cells by targeting the notch ligand interaction that with the endothelial cells. And you can deplete the pathological fibroblast directly by targeting the fibroblast activation protein, which is a protein that is an inflammatory fibroblast. You can target the make more antibodies that target these proteins in the inflammatory fibroblast so that they can detect these inflammatory fibroblasts and deplete these. And we already told that what makes the fibroblast into a fibroblastic memory is by epigenetic modification. There is a diffuse hypomethylation in aggressive phenotype of RA in fibroblast. So you can modify this so that you can erase that memory of forming property of this synovial fibroblast. You can do it by histone modifications or miRNA modifications. So one step ahead, we can target these cells by newer therapies also. You can get mesenchymal stromal cells, which is one of the upcoming field where you can get the mesenchymal stromal cell from bone marrow, adipose tissue, or umbilical cord. These has an immune modulatory properties like by paracrine actions, by growth factors, cytokines, or chemokines, or extracellular vesicles containing bioactive components. So if you in vitro studies showing culturing RAFLS with umbilical cord mesenchymal stromal cells down-regulated the Catherine level and MMP9, which will help in rheumatoid arthritis management. And if you polish little bit, the mesenchymal stem cells is secreting exosomes. So we can target exosomes also, which is the bioactive cargoes in mesenchymal stromal cells. And this has the non-coding RNA within it, and you can use exosomes and mesenchymal stromal cells. And immunomodulatory properties of these mesenchymal cells and exosomes can be modified by gene transfections also. And there are promising preclinical trials, but the clinical trials has mixed response, but it is very early to comment upon this. And there are some oligonucleotide small molecules like aptamers being tried in rheumatoid arthritis, targeting FLS, nuclein as one of the target of inflamed FLS already in pipeline in rheumatoid arthritis. So going one step ahead, you can also target the fibroblast by CAR T cells. One of the main newer thing is the fibroblast associated protein FAP. It is normally expressed in fetal tissue, but it is upregulated in solid tumors and synovium of RA. FAP is a marker of inflamed or inflammatory fibroblast. So you can have a CAR T cell therapy targeting these FAP positive fibroblasts. It is already successfully doing it in solid organ tumors. It can be extrapolated in rheumatoid arthritis also. So going to the fourth cell, that is follicular dendritic cell, which is a stromal cell lineage rather than other dendritic cell which has immune cells. And it is considered as a germinal center for autoimmunity. So it supports the autoreactive B cell, especially in synovium, as in tertiary lymphoid organs. And it is produced, enables a long-lived autoantibody production. It has a long-lived property of antigen presentation in rheumatoid arthritis synovium, and it persists despite of this immunosuppression also. And there are multiple methods tried in follicular dendritic cell targeting, like LT beta receptor pathways blocker, which disrupt the follicular dendritic cells. And the LT beta receptor molecule was successful in mouse models, but no benefit was there in human trials. And CXCL13 inhibitors, which can prevent the organization into an autoreactive follicles. And in rituximab, abatacept, JAK inhibitors, everything indirectly also causing FDC disruption. And in future, we can also see FDC targeted antibodies in rheumatoid arthritis treatment. And not even in rheumatoid arthritis treatment, even monitoring the rheumatoid arthritis disease activity, you can use these stromal cells, like stromal imprinting, which is the biomarkers that can be used on whatever proteins we have discussed, like Thy1, FAP, Catherine 11, Notch3, everything can be used as a biomarker for disease monitoring in rheumatoid arthritis. And FAP PET, which is a fibroblast associated protein PET, which is now used in solid organ tumors, can also be used in rheumatoid arthritis as for a disease monitoring purpose in the future. So concluding, the rheumatoid arthritis is not sustained by immune cells alone. Chronicity arises from a pathogenic stromal ecosystem. So to truly change the disease outcome, the future of RA therapy must also target the synovial fibroblast and its stromal partners. Thank you for giving me an opportunity to present.
Anybody has any questions for Dr. Anu?
Yes, FAP PET is actually just tried in malignancy, solid organ malignancy, where there is a lot of FAP expression in the tumor cell. In rheumatoid, fibroblast also express this FAP as a marker. So you can look at the disease activity, and also you can look at the fibrotic type of RA, where there is less number of immune cells, more of fibroblasts. You can identify that type of rheumatoid arthritis also with this FAP PET. Not available, but
Thank you, sir. Thank you, Dr. Anu, for the wonderful session.
Our next speaker for the day is Dr. Agustin Jose. He's the consultant rheumatologist at Rajagiri Hospital, Alua. He works in Department of Clinical Immunology and Rheumatology there. He has completed his MD from AIMS, Rishikesh, and he's done his DM Rheumatology and Clinical Immunology from JIPMA. He has received a grant from the IRA in 2023, and he has received an ICMR International Travel Grant for ACR Convergence in 2023 and a ULAR bursary for work on Takayasu arthritis in 2024. He has 20 publications, and his research interests are Takayasu arthritis and lupus. Over to Dr. Agustin.
Thank you, sir. Thank you so much. Warm good afternoon to all seniors and respected colleagues. Thank you for this topic, one for the future, I believe, liquid biopsies in autoimmune diseases. So the early clues to this concept actually started when people detected that the cell-free nucleic acids could be demonstrated in patients with tumors, and not surprising in lupus, which is all about DNA. And they have also demonstrated that this is quantifiable and it is also responsive to therapy. However, the breakthrough in the concept of liquid biopsy came actually through non-invasive prenatal testing, where Dr. Dennis Lowe demonstrated the presence of fetal DNA in the maternal serum, or in fact, actually better to say plasma. So this was further modified by digital PCR techniques, as well as later on massively parallel sequencing, or what we now know as the next generation sequencing, through which they were able to accurately predict trisomy 21 or other chromosomal aneuploidies. From there, the technological growth that occurred in genetic sequencing actually paralleled the evolution of liquid biopsy techniques, right from quantitative PCR techniques to digital PCR, NGS, And then comes exosomal biology, which is actually the source of most of the important nucleic acids in the circulation. And later on, from the last decade or so, it was widely adopted in oncology practice and research, leading to a rapid growth of liquid biopsy techniques. And thereafter, more layers of data got added to that with fragmentomics and epigenetic profiling. So at the core of all this concept lies the cell-free DNA, which is the DNA which is free of the cells or outside the cell, which is demonstrable in the plasma. So they could be of different morphology, it could be linear or it could be circular. This depends on the source as well as the tissue microenvironment, because the type of nucleases there can influence the morphology of the DNA. It could also be RNA of different morphology. It could be intravesicular or extravesicular, and the bulk of the nucleic acids in circulation is actually intravesicular. The source could be any biological processes, but most importantly apoptosis, because apoptosis you can find that they are short DNA fragments because it is a well organized process. At regular intervals the DNA gets cleaved, whereas more random cleavage occurs in necrosis, so you expect more larger fragments there. Pyroptosis or netosis could also trigger, and especially with netosis there is a lot of mitochondrial DNA which is being released. So in autoimmunity, we actually find a lot of small, short fragments of DNA. Now, as we told, just quantifying the DNA or the RNA in the serum or the plasma is not sufficient. We should be able to localize it to the tissue of origin. That is where the added layers of data comes, which includes methylation data as well as fragmentomics. So the methylation state of a circulating DNA resembles the tumor tissue. That was the first finding, and later on it was found that even in a case of lupus nephritis, the DNA can be localized to the tissue origin, which is the kidney. Again, depending on the nucleus structure or the organization or the nucleosomal arrangement, the fragmentation of DNA which is released into the circulation differs between tissues. So again, looking at this important detail can actually help us localize the free DNA that we are finding in plasma. Again, coming to cell-free RNA, RNA is of different types, the coding as well as the non-coding RNA. Because of the stability and more likelihood of getting incorporated into the extracellular vesicles, most often the studies use non-coding RNAs, especially the long non-coding RNAs, as the analytes. The revolution in exosome biology has actually triggered a lot of advancements in this field. So there have been techniques which have improved the detection of EV as well as the separation of EV and analysis of the cargo of the EV, which are the nucleic acids. You can see that there has been a lot of advancement again, which offers excellent isolation efficiency as well as analytical techniques to read out the whole cargo of the exosomal vesicles. Again, further expansions came with high-resolution EV analytic techniques like nanoparticle tracking, high-resolution flow cytometry, and later on, people have adopted a lot of multi-omics. So that is when we combine the data from different, analysis. It could be genomics, it could be transcriptomics, metabolite profile or metabolomics, or even epigenomics. And then came single cell and single vesicle technology with the single cell RNA sequencing. So in a tissue microenvironment, you can actually sequence a single cell and you can know what the sequence or that particular cell, how it is influencing the pathogenetic process. And again, after that, the machine learning platforms have revolutionized this field completely. So what exactly is a liquid biopsy? The source of this could be any fluid, most often the plasma, but it could be any other viable fluid also. And what are we analyzing? So at the core, we analyze the cell-free DNA or the cell-free RNA, which could be the free nucleic acid or whatever is contained inside the extracellular vesicles. You can use proteins or multiple biomarker molecules. So technically they are not liquid biopsy as such because they do not give us a molecular readout, but they could be liquid biopsy surrogates because some of these molecules could actually trace back to their cell of origin and have definite role in the pathogenetic process. Again, when I say circulating cells, I mean that the phenotype of the circulating cells could be predicted from the EV biology. And what is measured? A lot of data can be analyzed using the techniques available now. At the base, quantification of how much cell-free DNA is there, or all the genetic alterations, basically the mutations and copy number changes, epigenetics, fragmentomics, all the multi-omic processes can be analyzed with the current available techniques. So what makes it different from a biomarker? So we know that the biomarker is a single analyte, whereas a liquid biopsy, it is mostly multiple information or different layers of information compiled into it. and most often the DNA, RNA, or the extravesicular contents. And this originates directly from the diseased tissue and not just from any systemic process or a byproduct. And it has high complexity and it has a temporal resolution also. Most often they are dynamic, and the cell-free DNA, the half-life is actually a few seconds to minutes. And the primary purpose is to replace a biopsy, get a virtual biopsy. So it can identify the tissue of origin non-invasively. So not all biomarkers qualify as liquid biopsies. Those are, reserved for biopsy replacing molecularly rich readouts of the DNA or RNA. So you can see how it has revolutionized the tumor management, right from the detection, screening, early diagnosis, profiling or prognostication of the case based on the clone that is there or the mutations that are detected. While you're treating the disease, looking at the minimal residual disease or MRD, getting the response to treatment, and when you have a relapse, look at the different clones. If it was the original clone that is relapsing, or is it a different clone, whether a different type of treatment is required. So all such data is available from cell-free DNA or the circulating tumor DNA. So when we go more into detail, we should understand that the cell-free DNA is not just for diagnostics, actually has a pathogenetic role because it could be pro-inflammatory, as we expect in lupus. So what makes it pro-inflammatory? Any mitochondrial DNA is intrinsically pro-inflammatory because it has a lot of CpG motifs. It is resembling a prokaryotic DNA, and it is sensed by TLR9 as well as the STING pathways. Diseases with oxidative stress leads to more of DNA oxidation, which again is a pro-inflammatory feature of that. Even though it is cell-free, it could gain access into the intracellular compartment through carrier proteins. Now, in cell-free DNA in lupus, elevated levels have been demonstrated which fluctuate with disease activity. This is independent of the anti-DS DNA binding. High CpG dinucleotides, more hypomethylation, more oxidation have been noticed. And look at this abstract. So I have focused on more recent data. So look at this abstract in ACR 2025. They have looked at cases with active and non-active lupus nephritis. They have looked at the different tissue-specific signatures, used machine learning, tried to deconvolute the data, and they have seen that there is a very accurate prediction of active lupus nephritis based on this fragmentomic and methylation data. Again, another important aspect is the circulating microRNA. So this is one meta-analysis that has assessed and has found out reasonable accuracy in predicting an active disease or diagnosing lupus, but some of the important candidates being microRNA 146A or 29. Then we have the non-coding RNA in lupus, which previously we were not sure about the role of this in the cell biology, but it was later found that they have a very important coordinating role in how the microRNAs or the other RNAs influence the transcription process or the post-transcriptional regulations. And it was found that the key cytokine axes that were involved were the interferon-mediated processes, and some of these long non-coding RNAs were matching with the interferon pathways. And also the regulation of B cell, which is the next important process, which again predictable with the long non-coding RNAs which were isolated. More specific to lupus nephritis, I would be saying is the urinary analysis of the liquid biopsies. So extracellular vesicle RNA in lupus nephritis is a promising tool where they have found that some of the EV RNAs which are listed here, they could accurately distinguish between active and lupus nephritis in remission or non-nephritic and nephritic lupus. So these are also again another promising tool. So as I said, the biomarkers like CD163, they are not strictly liquid biopsy, but they are liquid biopsy surrogates because they could be attributed a role in inflammation. So in lupus nephritis, there is a shift from M1 to M2 phenotype, most often associated with fibrosis as well as a reduced clearance of immune complexes. So they are definitely involved in pathogenesis, and CD163 is a marker of the M2 macrophages. So this is something that has come up which can closely correlate with clinical severity. The levels could be increased as early as 6 months prior to a flare, so good predictive value, and it is responsive to treatment, so it diminishes progressively in complete and partial responders, and it remains elevated in non-responders. So then looking at a single biomarker may not be good, so there's a panel of biomarkers that has been tested. So you can look at this study or the abstract that has been presented recently. So they looked at all lupus nephritis with a proteinuria that is just below 0.5, so 0.25 to 0.49. And and with an additional nephritic risk factor, either in the form of race, low complements, anti-DSTN, or active urine sediments. So 13 of these 21 patients actually had biopsy-confirmed lupus nephritis, and this multi-biomarker panel could accurately predict lupus nephritis even when the presence of a sub-significant proteinuria. Again, proteomics. When we say proteomics, we mean that this is not just a biomarker measurement, it's a large-scale analysis of all the proteins in that analyte, either using mass spectrometry or other platforms like SomaScan. So they give you an idea of the pathogenetic processes that are active in a particular disease. So using this, we have demonstrated that pathways of monocyte or neutrophil degranulation, macrophage activation, or other matrix components have actually have the ability to predict the class of lupus nephritis as well as the response to therapy. Again, just summarizing rheumatoid arthritis, same kind of pathogenesis. You have pro-inflammatory DNA there. And we have data to say that you can accurately predict early rheumatoid arthritis, you can predict the response to drugs, you can track the activity, you can predict flares, or see the response to particular biologic drugs, and possibly in the future, you have multi-analyte RA dashboards that is coming up. One important aspect in systemic sclerosis would be the ability to predict which patient might have a future fibrotic phenotype or an aggressive phenotype, and this is where the data from circulating EVs have given us very promising results. So the analysis of circulating ICAM EVs or exosome proteomic signatures, they were able to identify ILD or patients with and without ILD. So this could be one future aspect where we would be able to predict which patient might be going into an ILD and who requires a more aggressive approach. So what are the challenges that we are facing now? All of our diseases have a lot of heterogeneity. There are multiple immune pathways that are involved. The techniques for EV isolation, the fragmentation techniques or the miRNA isolation are yet to be standardized. And as of now, we have only small cross-sectional data, which are basically discovery cohorts. So you need more of longitudinal data. You need measurement of these analytes with every flare. You need to follow the patients. You need to see the differences between the responders and non-responders. So there is a lot of work to be done in that. And yet, with all this genomic or transcriptomic data, especially in diseases with multiple immune pathways, we have a lot of complex signal-to-noise problems. So they could be on steroids, they could be having infections. So all of this could actually influence the analysis of liquid biopsies. And obviously, with any of these advanced techniques, we have cost and infrastructure limitations, which are yet to be solved. Yet, I think the future is bright, and our ability to predict a disease early than when it goes to a late stage would be the most important aspect of a future treatment that we are able to offer to our patients. Thank you.
Thanks. Thanks, Dr. Agustin, for the wonderful talk. Any questions for him?
So, Agustin, wonderful talk. So there is a lupus kidney, and there are so many cells within that lupus kidney, and there is a normal kidney.
Okay.
So if we do the serum, and we are looking for the cell-free DNA, they will be able to say us that the DNA is from an autoreactive B cell and a macrophage, and it is inflamed and it is pathogenic.
Exactly, sir. Exactly. One is the quantification. Oh, is your question complete, sir? Sorry.
Like there is a normal kidney also, it also produces the same like cell-free DNAs.
Definitely. There have been, so first of all, the quantification would be different. So the amount of DNA from the diseased kidney as well as a normal kidney would be different. And even in that abnormal amount of DNA that you have, there would be differences between active state. Just like I told, there's a difference between M1 macrophage and M2 macrophage. So one phenotype would be associated with the pathogenic state and one would be with the normal state of kidney. So definitely, yes, the profile of cells, whether they have become pro-inflammatory or not, could also be detected potentially using the cell-free DNA techniques. Yeah.
Okay. Yeah. So one more. Yeah. So how do they, like they are, some of them are purely tissue.
Yes.
They won't be there in, the cells may not come out.
Exactly.
But you are saying the cell-free DNA can come out.
Definitely. That is where exosomes come. So they are secreting out their cargo, the endosomal cargo or the cytosolic cargo into the ECF through extracellular vesicles. So the bulk of all of this actually is contained within the extracellular vesicles, not as free DNA. The free DNA is still measurable, but it's a very limited quantity. More reasonable or more feasible measurement would come from the extracellular vesicles.
So those vesicles will be released from the tissue,
Yes,
the cells,
yes.
and they will wander around.
Even normal tissues and diseased tissues also, with a differential rate of release as well as the content, difference in the content also.
Okay, one single extrasomal vesicle will have cfDNA, RNA, miRNA,
yes.
everything will be there within that
in
vesicle.
one single exosome.
And if you can get that vesicle, that will tell the
Definitely. So there is, the technology has gone to single vesicle techniques also. Just like a single cell RNA sequencing, it has gone to single cell. Not yet come up in our field, but yes, definitely.
Thank you.
Thank you, sir.
Any more questions?
I came late, but I saw your presentation whatever I saw was very nice. Thank you. Just one comment on this. I remember when Suma Madam Dr. Satish conducted the CMC Pediatric Rheumatology Conference, I had a talk, and that was on urinary proteomics. That was in 2012. I think one technology which has still been under evaluation but not still come to clinical level is probably the urinary proteomics. Despite even at that time there was comprehensive biomarkers, some 17 biomarkers were studied, and when they put together there was certain prediction of they were useful in predicting flare and disease. But somehow this is taking a long time. Not sure what that why what is stalling it.
It's not coming out of the research settings.
Yes.
Yeah, that's true.
Okay, thank you.
Thank you so much.
Then we can move to the next.
Now, the final topic of this session, assessing interstitial lung disease in systemic sclerosis by Dr. Sridevi. She is the assistant professor of rheumatology in Government Medical College at Trivandrum. She is also honorary consultant in Sritra Institute. Over to you, sir.
Thank you, sir. So, thank you, Calicut Rheumatology organizing team for inviting me and giving me this opportunity. So, my topic would be the assessment of scleroderma ILD and what is new. So, why we need to know about this is, in scleroderma patients, 75 to 90% of them have some sort of CT abnormalities, of which more than 50% has got interstitial lung disease, in which 40% of them has got a severe disease phenotype, and they account for more than 35% death in scleroderma. So the progression occurs more in the first 5 years of scleroderma, and identifying and managing those at risk of progressing ILD is very much important to prevent further loss of lung function to improve the survival. So the causes like only one third of them have a stable lung function after 5 years, and the most progression occurs in the first 5 years, and those who progress in the first year, they go on to progress very badly during the next 5 years. And this combined pulmonary emphysema and pulmonary fibrosis phenomenon, that portends a very bad prognosis for survival. So what to assess in scleroderma interstitial lung disease? So basically, for every scleroderma patients, we assess the risk factors for the development of ILD as well as for the progression of ILD in them. We assess the phenotype, whether it is diffuse cutaneous or limited scleroderma, because diffuse cutaneous scleroderma, they have more chance of getting ILD and more chance of progression over years and duration, and they are likely to progress more in the first 5 years, and during which intense monitoring is required when compared to the latter part of the disease. And antibodies which are more likely to produce progression are mainly topoisomerase antibodies, and biomarkers of which I will be talking about, and high ESR CRP again portends bad prognosis for progression. So for everybody, for all patients, we need to assess clinical symptoms. Basically, they are cough and dyspnea, and we look at the physical examination. We do look for the clubbing, and everybody should be subjected to HRCT chest and pulmonary, and if by HRCT chest, if ILD is detected or clinical symptoms suggestive of ILD, we do a PFT. We look at the lung volumes, FVC and DLCO, and we make them to do the 6-minute walk test and the ambulatory desaturation test. So this is the latest guidelines. That is the European respiratory physicians and EULAR rheumatologists, European rheumatologists, they have come together and they have formulated this set of guidelines which has come up in 2025. And these were the three guidelines which had come up in 2024. That was EULAR, ACR, and American Thoracic Society. So the latest one is the ATS, EULAR and ERS formulated one, of which, so most of the content has been taken from the latest guidelines. So as they say, it is a longer duration. The more the age of the patient, more chance of ILD, and increased topoisomerase, more chance of ILD, and increased KL6. So this is a marker of epithelial cell injury in lung. So they are said to be having more chance of interstitial lung disease and rapid onset skin tightening and diffuse scleroderma. So other than this, the RNA polymerase 3 antibody, U3 RNP antibody, THTO, and the nucleolar pattern antibody. So all these have they have more chance of developing ILD in the scleroderma patients. And we need to look for the risk factors of ILD progression. Why? Because for the monitoring purpose, we do categorize them into the high risk and the low risk population. And the high risk population, we need to monitor them using this technologies more frequently when compared to the low risk people. So as already told, ESR CRP it portends high risk for progression, and baseline PFT. So already the baseline FVC less than 70, more chance of progression, and DLCO less than 55, more chance of progression. We know that FVC will be reduced. Usually in the FVC is the forced vital capacity, that is the amount of air that is exhaled out after a maximum inspiration. It is low in interstitial. It will be low in interstitial lung disease. So we do look at the FVC, DLCO, and DLCO is assessing the diffusion of the gases, and that will be low in ILD as well as in the pulmonary artery hypertension. So by imaging, if the HRCT features more than 20% of them has got radiological involvement, more chance of progression, and the skin involvement. So these are through the different studies, we have found out that these are the common set of things which predict the progression. And other than that, GRD is also one of the feature for, it's a risk factor for progression of interstitial lung disease. So no matter what the risk factors, all scleroderma patients that we come across should be screened for ILD by HRCT chest. Why? Because in the U-star cohort, it was found that those scleroderma patients who had ILD, only 21% of them had disease duration less than 3 years, and only 50% of them were positive for topoisomerase, and only 50% of them were diffuse cutaneous scleroderma patients. So we need not go by the risk factor method. We have to screen everybody, all scleroderma patients by HRCT for interstitial lung disease. So basically, we do the HRCT and PFT and the clinical examination for screening. And why HRCT chest? It is the most sensitive and specific gold standard method, and it is used for screening, monitoring, and prognosticating. And what do we look for? We look for, as initially itself I've told, like pulmonary emphysema and fibrosis, both of them carries a bad prognosis. We do rule out infection and lymphadenopathy, because coexisting tuberculosis may be there. Esophageal dilatation, again we have to target the GRD, because that again makes the progression of ILD bad. And malignancy, many patients who come in the latter phase of their life with seronegative scleroderma, they may harbor a malignancy, so mostly lung CA. So HRCT chest helps to pick up that too. And pulmonary artery hypertension, which may be picked up by the pulmonary enlargement. So HRCT chest usually done by supine inspiratory scan, and supine expiratory scan helps to detect the air trapping, and prone is to assess, differentiate between the atelectasis and the ILD. So early ILD may be picked up in the atelectasis may be missed. It may be misunderstood. And newer reconstruction algorithms may be used to avoid the false positive honeycombing. So for any ILD patient, we should assess the clinical risk factors: lung function test, HRCT, 6-minute walk test, oxygen desaturation, and the patient reported outcome measures. So monitoring we do by all these parameters as well as the patient reported outcome measure. So this, why do we need to do the monitoring? Why? Because those who had a normal PFT in the first year may progress, may have a decline and may have a decline in FVC over this 5 years. So this the portion which has been highlighted as 9%, 14% and 14%, this is a U-star cohort again, which show that 30% they have, even though they have a normal PFT, they have a decline in, even though they don't have symptoms, they may have a decline in FVC. So we need to do monitoring in them. And 2/3 of the patients with HRCT showing scleroderma ILD, they have a normal, most of them, they had a normal PFT, and half of the patients with a normal PFT had a SSC ILD, and 30% of the patients were asymptomatic. So that still makes HRCT being the ideal screening tool and the monitoring tool. So for monitoring, we again categorize the patients into high risk and the low risk. And high risk, we monitor them more frequently, more frequently. So and again, in the high risk and low risk, we divide it as less than 5 years and more than 5 years, because in the first 5 years, the progression is likely to be more. So the lung function test, it is done every 3 to 6 months in the first 5 years, and after 5 years, it is done every 6 to 12 months. Whereas in the low risk category, we do it every 6 to 12 months in the first 5 years. And after that, after 5 years, we prefer to do it annually. And HRCT for the low risk people, it is once in 2 years in the first 5 years. And in high risk people, we need to do it every annually. So as against what was said earlier, we usually do only if there is clinical progression or whenever there is a fall in PFT. So actually, we need to do for the high risk people, HRCT has to be repeated annually. And 6-minute walk test and oxygen desaturation has to be done for high risk group every 6 to 12 months in the first 5 years, and for the low risk group annually. And patient reported outcomes also has to be tested in the high risk groups every 6 to 12 months, and for the low risk every 12 months. So why patient reported outcome measure? So this actually, it is the patient's perspective. So it actually helps us to analyze the symptom and the quality of life, their mental, physical ability, their workplace coping up, or their social life, or their work at home. So that also helps to assess the treatment efficacy and disease severity. So there are usually this patient reported outcome measures are usually divided as the generic ones, that is the ones which are validated for many other rheumatic diseases like SF36, short form 36 and FACET, all those things, they are a generic this thing. And whereas for the specific ones are the Leicester cough questionnaire, Malus transition index, that is specifically for the dyspnea, cough, etc. So this has been tried in, so basically for the dyspnea, they have got a set of PROMs, and for the cough, they have a set of patient reported outcome measures, and for assessing quality of life, we do the SF36 or St. John's respiratory questionnaire, etc. So this has been done in many of the landmark studies as well to assess the quality of life, dyspnea, cough, fatigue, etc. So why do we do the PFT? So PFT, as I already told, the frequency of doing PFT, and we need to monitor the severity, progression. It helps to identify, because identify in case the patient has some anemia or respiratory muscle weakness or skin tightening, or even DLCO fall more than FVC fall may point towards pulmonary artery hypertension, and it may be altered with infection also. So what is stable PFT? The FVC decline less than 5%. So more than anything more than that is said to be. So the definition of progression will be discussed. So we need to do the PFT initially as well as on follow-up to know the progression. So update in the definition of progression, but no definite idea about the progression has been mentioned in the latest guideline. But these are the guidelines that has been used over years, and the one that is normally followed is FVC decline more than 5 to 10% over 1 year. So FVC decline, the first value of FVC and the repeat value, the decline somewhere between more than 10% over 1 year is considered significant. And these are the other criteria that they have built. Like inbuilt criteria is the one which was used for the inbuilt study for CTD ILD. So they usually, it said that FVC decline more than 10%, or the FVC decline 5 to 9% with the respiratory progression or with respiratory symptoms or the radiologic progression. So we tend to use the FVC decline more than 10% over 1 year. So the ILD, the mere presence of ILD itself portends a very bad mortality over a 5-year mortality survival rate being 69 and 10-year survival rate being 56 according to many of the studies. So this was one of them. So the extensive study said to be extensive disease is said to be summating both FVC less than 70% and HRCT involvement of chest more than 30% indicates extensive disease. And so this is a 6-minute walk test. So the patients are asked to walk for 6 minutes. So normally they should walk at least 400 to 700 meter, but then anything less than 300 is said to be pathogenic. So not pathogenic. It is said to be indicating of some kind of weakness, respiratory weakness. But the issue with the 6-minute walk test is that it can be affected with lower limb arthritis, pulmonary artery hypertension and myositis. So basically it is used for the monitoring purpose. So the patient is asked to walk over a period of 30 meter in the rounded direction, and then we measure the distance that is walked by them, and then so normal is the 400 to 700 meter, and then we can also measure the saturation. So saturation, so that is what we call the ambulation desaturation. So when there is on ambulating, whenever there is desaturation, that means it portends to maybe the presence of interstitial lung disease. So BAL and bronchoalveolar lavage and lung biopsy both are invasive, and they can lead to bleeding or pneumothorax and all. So hence not usually preferred unless we have a doubt of infection. So that could make us do BAL, because BAL itself may lead to flare of interstitial lung disease. So only if we have suspect infection and diffuse alveolar hemorrhage, we go for BAL. So that again guides prognosis. Higher neutrophil count, more extensive disease on CT. So inflammatory BAL, again more severe restrictive ventilatory defects. So always rule out the cardiac conditions, GRD, and the skeletal and the respiratory muscle involvement. So what are the innovative approaches? What has come up new in the SSC-ILD? So this is a photon counting CT, which is a low dose CT with less amount of noise involvement. So that can actually interpret the GGOs, reticulation, honeycombing. They can be well made out, and the slices are as thin as 0.2 millimeter, and it has a good spatial resolution as well. So early subtle initial presence of ILD could be made out, and extent could also be found out. So that is a photon counting CT. Then there is something called as impulse oscillometry. So for the pulmonary function test, the patient has to have give the effort. So this is actually patient cooperation is not much needed. So they do the normal breathing, and the sound waves are introduced into the airways. So that is a measure to identify the small airway disease as well as interstitial lung disease. So this was a study which was conducted in the European population. So they differentiated the extensive and limited interstitial lung disease using this impulse oscillometry, wherein they have a particular parameter called as a frequency resonance. So normal frequency resonance is 7 to 12 millimeters. So anything like more than 12, the patient may have restrictive lung disease. So this is actually a non-invasive and effort-independent method for detecting presence and severity of SSC-ILD, especially in old age people or young kids, so less involvement of the patient. So this is the latest technology, which is the electronic nose technology. So here the exhaled gases with the patient ILD, they are collected into a walkie-talkie machine, and then it is sensed by the sensors, and they give a breathing fingerprint. So in case of inflammation, the certain set of breathing signature gases will be present, and when not in inflammation, another set of breathing signature may be present. So this is a novel method. So this has been studied in scleroderma also. So biomarkers, so they help to identify, they may help, so it should be called ideal only when it helps to identify the scleroderma at a very early stage. So autoantibodies which are usually attributed are PMSCL, TH2 and anti-topoisomerase. So novel markers are KL6, surfactant protein D and the chemokines like CCL18. And there are a whole set of other chemokines, adhesive factors, etc. So this is a ILD risk score which was formulated by Bruni et al. So the risk score says more than 0.3% more chance of ILD. So this can be used in a resource poor setting where the HRCT cannot be offered for everybody. So this uses the parameters like FVC, DLCO, digital ulcer, age and scleroderma autoantibody. It has a sensitivity of 85 and specificity of 53 and it has been validated in multiple scleroderma cohorts. So this is an artificial intelligence picture. So here we can say that the color coding has been done according to the lobes like upper lobe, middle lobe and the lower lobe, and the color coding has been done according to the GGOs or the reticulation. So hence that will help to quantify the amount of, using the texture analysis they have quantified the GGOs, reticulation, etc. So it can be used to find out the progression over the months and help to assess the treatment efficacy also. So this is the calipers which is a computer aided methodology to know the lung informatics. So lung ultrasound, it's another cost effective method, so that in which we look for the B lines. So B lines are the vertical lines which may be seen, which is not specific for interstitial lung disease. It can be seen in pulmonary edema as well. So they may be used. It is never a substitute for the PFT, but it may be used whenever there is a resource poor setting. So B lines, they are the ultrasonic waves which are reflected from the interstitial septal lines due to fibrosis. So it can be used in resource poor setting. So these are the vertical lines which are depicted, which is the B line, which is seen usually in ILD. And MRI scleroderma ILD. MRI in scleroderma ILD, it may be able to pick up the inflammatory stage from the fibrotic stage. So the high intensity T2 weighted sequencing it indicates inflammation, and fibrosis is indicated by the low signal intensity T2 images, and so that is dictated by the ultra short time to echo MR sequence. So this actually cuts down the amount of time that is required for the usual MRI. So this is a ultra short time to echo, which helps to bring down the time and avoid the patient holding breathing for a long period of time. And again, another functional MRI is using this hyperpolarized gases like xenon and helium and to assess the diffusion of these gases across the interstitium. So if it is impaired, that means the lung has got a restrictive lung disease. And now the FAPI PET is already told, so that we pick up the fibroblast, the activated fibroblast, not the resting fibroblast, activated fibroblast, so that will help to pick up the inflammation. This is the FAPI gallium labeled selective inhibitor of fibroblast activation protein. So it helps to identify the ILD at an early stage, as well as help to monitor the progression. So this has been the lot of trials that has already been, we all know about all this landmark trials, and after which MMF has emerged as the first line option. So for interstitial lung disease and scleroderma. So this is a chart showing the treatment of scleroderma ILD. So again, MMF stands as the first choice for them, and the early changes, the early inflammatory scleroderma may be given tocilizumab, and if the FVC is more than, the fibrosis is more than 10%, they may be offered nintedanib. And if there is high risk of progression, they may be offered combination drugs or rituximab and cyclophosphamide. So newer perspectives, so we may target the BAF by belimumab or anifrolumab, which is the interferon, targeting the interferon receptor. So that actually serves as a balance between the innate and the adaptive immunity. So anifrolumab may be used. All these are in the exploratory phase. And low dose interleukin-2, it actually helps to increase the Treg cells. And amivantamab, so this is again anti-CD40 ligand, so that prevents the T cell activation. And phosphodiesterase 4B inhibitor prevents the inflammatory cytokine release and prevents its amplification. Nerandomilast is the drug. And CAR T cell, it will inhibit the B cells for a longer period of time, as well as the tissue resident B cells for a longer period of time. And anti-CTGF, that is a connective tissue growth factor. So that again, fibrosis is the main cause of it, and the molecule for which is TGF beta, we may act against it using the pembrolizumab. So this is the newer perspective. So anybody with screen for ILD using HRCT, PFT, 6-minute walk test and ambulatory desaturating testing, and monitor according to the high risk and low risk. So high risk groups have to be monitored very frequently when compared to the low risk, and future directions are the newer HRCT modalities using the artificial intelligence or the calipers method, FAPI-PET and the lung ultrasound in the resource limited areas, and MRI. So thank you. So that's all.
Thank you for the excellent talk. Any questions? We are lagging behind time, so 1 or 2 questions.
Thank you, Dr. Sridevi, for the excellent talk. Regarding, it's a practical question. In Government Medical College Trivandrum, regarding the screening you said for HRCT in a patient with scleroderma, will you be able to follow the screening in your patients?
Yes, I do that, because we have a lot of insurance schemes, and also, and a lot of the patients, even though they are not very much educated, so if we like make them understand, and we have a word with the pulmonologist too, so then most of them understand the depth of the situation and they go through it as well.
And once you get it, like patient asymptomatic, and you get it, and how will you, is it possible to convince them, and like early ILD, if you detect?
Most of them like on to treatment part also.
Treatment part, like while counseling the patients, like totally asymptomatic patients, is it possible in your busy OPD? That's what I was
because we will have to counsel them regarding the high risk factors and all those things. Basically for MMF we offer for all, even because it does good for the skin fibrosis as well. So MMF has to be the part and parcel, and
no, not regarding that. Like totally asymptomatic patients, and especially MMF and all.
So like we have to give them the idea about the chance of mortality over the years, and then the chance of progression over the years. So most of them, I feel, they get convinced and they do, and they try to adhere on the treatment maximum possible. So in fact, when we give them the idea about rituximab or cyclophosphamide, they are very much eager, because most of them they got good access to media, and also they keep updated about it, so they know.
Because of the insurance schemes, you are able to do.
We are able to do.
Thank you.
One more question, Joe.
I think it's not a question. The most important thing when you do an HRCT ILD is to do a ILD protocol, which you have already mentioned. Without that, interpretation would be never complete. So you have to do an inspiratory, expiratory, prone images, and that too ideally in a 1 millimeter cuts. And that is very important to especially differentiate between dependent abnormalities, ILA, interstitial lung abnormalities. So many different things are there. So whenever you order an ILD in your practice, because routinely what we all do is HRCT test. That is not really useful. You have to specifically mention HRCT ILD protocol. We have created a separate protocol in our hospital, and of course they charge more when you have more number of this thing, but that is, I think, is essential. I think you would agree with that.
Yes, sir, definitely.
Thank you, Joe. I think we will conclude the session. Thank you, Sudhir.
Thank you, sir.
We'll conclude the session, and we'll have a short tea break, and we'll assemble back at 4. Like we can have it from behind.